Welcome to our deep dive into osseointegration, a fascinating process at the heart of modern implantology. Osseointegration refers to the direct attachment of bone tissue to an inert, alloplastic material, such as a dental implant, without any intervening connective tissue. This unique connection is crucial for the stability and longevity of implants, especially in dental and orthopedic applications. Throughout this video, we'll explore the science behind osseointegration, compare it to other integration mechanisms, and examine the theories and steps involved. Let's begin by understanding what makes osseointegration so special and why it's a cornerstone of successful implant procedures. Osseointegration is defined as the apparent direct attachment or connection of bone tissue to an inert alloplastic material, such as titanium, without any intervening connective tissue. This means that the implant surface and the host bone are joined together seamlessly, forming a stable interface. Unlike other forms of integration, there are no scar tissues, cartilage, or ligament fibers between the bone and the implant surface. This direct contact can be verified microscopically, ensuring that the implant is securely anchored within the bone. The absence of soft tissue at the interface is what distinguishes osseointegration from other types of implant integration. The interface between the alloplastic material and bone is a critical aspect of osseointegration. It is characterized by a direct connection with no soft tissue layer present. This interface is essential for the implant's stability and function. Osseointegration is often described as the formation of a direct interface between an implant and bone, without intervening soft tissue. This ensures that the implant is firmly held in place, allowing it to withstand functional loads and provide long-term support. The quality of this interface determines the success of the implant and its ability to integrate with the host bone. An osseointegrated implant is a type of endosteel implant that contains pores into which osteoblasts and supporting connective tissue can migrate. This design facilitates the integration of the implant with the surrounding bone, promoting the growth of bone tissue right up to the implant surface. In oral implantology, this means that the bone grows directly onto the implant, without any interposed soft tissue layer. The result is a stable and secure implant that can support functional loads. The direct contact between bone and implant surface is a hallmark of osseointegrated implants, ensuring their long-term success. The direct contact between bone and implant surface can be verified microscopically. This verification is essential for confirming successful osseointegration. Under the microscope, there should be no evidence of scar tissue, cartilage, or ligament fibers between the bone and the implant. Instead, the bone should be seen growing right up to the implant surface, forming a seamless connection. This microscopic evidence is a key indicator of the quality and success of the osseointegration process, ensuring that the implant is securely anchored within the bone. Osseointegration is distinct from fibro-osseous integration, where soft tissues such as fibers and cells are interposed between the bone and the implant surface. In fibro-osseous integration, the presence of these soft tissues can compromise the stability and function of the implant. Osseointegration, on the other hand, ensures a direct and stable connection, free from intervening soft tissue. This difference is crucial for the long-term success of implants, as osseointegration provides a more robust and reliable fixation within the bone. Brånemark's theory of osseointegration revolutionized implantology. He proposed that implants integrate with bone such that the bone is laid very close to the implant, without any intervening connective tissue. Brånemark's research in the 1950s demonstrated that titanium-oxide permanently fuses with bone, creating a stable and lasting connection. This theory laid the foundation for modern dental and orthopedic implants, emphasizing the importance of direct bone-to-implant contact for successful integration. One of the key discoveries by Brånemark was the permanent fusion of titanium oxide with bone. This fusion creates a stable interface, allowing the implant to become a functional part of the skeletal system. Titanium's biocompatibility and ability to bond with bone tissue make it the material of choice for many implants. The fusion process ensures that the implant is securely anchored, providing long-term support and functionality. Brånemark's pioneering research in the 1950s demonstrated the potential for titanium implants to integrate directly with bone. His experiments showed that the bone could grow right up to the implant surface, without any intervening connective tissue. This discovery paved the way for the development of modern implantology, providing a scientific basis for the use of titanium in dental and orthopedic implants. The lasting impact of Brånemark's work is evident in the widespread adoption of osseointegration principles in clinical practice. Weiss's theory of fibro-osseous integration offers a contrasting perspective. According to Weiss, a fibro-osseous ligament forms between the implant and the bone, similar to the periodontal ligament found in natural teeth. He argues that collagen fibers are present at the bone-implant interface, creating a peri-implantal ligament with osteogenic effects. Weiss advocates for early loading of implants, suggesting that this ligament can support functional loads soon after placement. Weiss likens the fibro-osseous ligament to the periodontal ligament found in the gomphosis of natural teeth. This analogy highlights the presence of collagen fibers at the bone-implant interface, which can provide some degree of flexibility and support. The peri-implantal ligament is thought to have osteogenic effects, promoting bone growth and adaptation around the implant. This perspective emphasizes the role of soft tissue in implant integration, contrasting with the direct bone contact seen in osseointegration. Weiss advocates for the early loading of implants based on the presence of the fibro-osseous ligament. He believes that this ligament can support functional loads soon after implant placement, reducing the waiting time for restoration. This approach contrasts with Brånemark's recommendation to avoid loading during the healing phase, highlighting the ongoing debate in implantology regarding optimal loading protocols. The process of osseointegration involves several key steps and factors. 4 main factors influence successful osseointegration: biocompatibility of the material, implant adaptation to the prepared site, atraumatic surgery, and an undisturbed healing phase. These factors work together to ensure that the implant integrates seamlessly with the host bone, providing a stable and functional connection. Biocompatibility of the implant material is essential for successful osseointegration. Metallic, ceramic, and polymeric materials have been used, with titanium being the most popular due to its excellent biocompatibility and ability to bond with bone tissue. The choice of material affects the integration process and the long-term stability of the implant. Proper adaptation of the implant to the prepared site is crucial for osseointegration. The implant must fit securely within the bone, minimizing gaps and ensuring direct contact. This adaptation promotes bone growth onto the implant surface, facilitating stable integration and long-term success. Atraumatic surgical techniques are essential for preserving the integrity of the bone and promoting osseointegration. Minimizing trauma during implant placement reduces inflammation and supports the healing process. Careful surgical procedures ensure that the bone remains healthy and capable of integrating with the implant. An undisturbed healing phase is critical for osseointegration. The implant must be left out of function during this period, allowing the bone to grow onto the implant surface without interference. This healing phase typically lasts several weeks or months, depending on the patient and the implant site. Proper healing ensures a stable and robust connection between the bone and the implant. For osseo-integrated dental implants, a variety of materials have been used, including metallic, ceramic, and polymeric options. Titanium remains the most widely used material due to its biocompatibility and ability to form a stable bond with bone tissue. The choice of material influences the integration process and the long-term success of the implant. The essence of osseointegration derives more from the stability of the fixation than the degree of contact in histologic terms. While the connection between bone and implant does not need to be 100%, the stability provided by the integration is what matters most. Clinically, asymptomatic rigid fixation of the implant is achieved and maintained during functional loading, ensuring long-term success. Osseointegration allows the implant to withstand functional loading, meaning it can support chewing and other forces without becoming loose or unstable. The process ensures that the implant is tightly held in place by the bone, providing reliable support for dental restorations and other prosthetics. The process of osseointegration typically takes several weeks or months to occur. Initial evidence of integration can be seen after a few weeks, while a more robust connection develops over the following months or years. The degree of osseointegration improves with time, providing increasing resistance to external shocks and functional loads. The timeline for osseointegration is well suited for implant dentists to complete restorations. Once the implant is securely integrated, restorations can be placed, providing functional and aesthetic benefits to the patient. The timing of restoration depends on the degree of integration and the stability of the implant. As osseointegration progresses, the bone-implant interface becomes increasingly resistant to external shocks and functional loads. This resistance is essential for the long-term success of the implant, ensuring that it remains stable and functional even under challenging conditions. Despite the robust connection achieved through osseointegration, prolonged adverse stimuli and overload can damage the interface, leading to implant failure. It is important to monitor and manage functional loads to prevent excessive stress on the implant and ensure its long-term success. Studies on dental implants have shown that the absence of micromotion at the bone-implant interface is necessary for proper osseointegration. There is a critical threshold of micromotion, above which a fibrous encapsulation process occurs instead of osseointegration. Maintaining stability during the healing phase is essential for successful integration. Brånemark emphasized that the implant should not be loaded and must be left out of function during the healing period for osseous integration to occur. This protocol ensures that the bone can grow onto the implant surface without interference, promoting stable and successful integration. The osseointegration process involves several distinct steps. First, woven bone is formed in the gap between the implant and the bone. This bone grows rapidly, up to 100 micrometers per day in all directions, with random orientation of collagen fibrils and high cellularity. After 1 to 2 months, woven bone is progressively replaced by lamellar bone under load stimulation, which becomes stable after about 1.5 years. The first step in osseointegration is the formation of woven bone in the gap between the implant and the bone. Woven bone grows quickly, up to 100 micrometers per day, and has a random orientation of collagen fibrils. This bone is highly cellular, but has low biomechanical capacity, so occlusal load needs to be controlled during this phase. After 1 to 2 months, woven bone is progressively replaced by lamellar bone under load stimulation. Lamellar bone is more organized and provides greater biomechanical stability. This replacement process continues until the bone is stable, usually after about 1.5 years. The transition from woven to lamellar bone is essential for the long-term success of the implant. Load stimulation plays a crucial role in the replacement of woven bone by lamellar bone. Controlled functional loading encourages the formation of stable, organized bone tissue around the implant. This process ensures that the implant can withstand functional forces and remain securely anchored within the bone. Woven bone grows at a remarkable rate, up to 100 micrometers per day in all directions. This rapid growth is essential for filling the gap between the implant and the bone, providing a foundation for subsequent lamellar bone formation. The high cellularity and random orientation of collagen fibrils characterize this phase of bone growth. During the woven bone phase, collagen fibrils are randomly oriented, contributing to the bone's high cellularity but low biomechanical capacity. This random orientation is gradually replaced by the organized structure of lamellar bone, which provides greater stability and strength. Woven bone has low biomechanical capacity, making it essential to control occlusal load during this phase. Excessive functional loading can compromise the stability of the implant and hinder the integration process. Proper management of load ensures successful transition to lamellar bone and long-term implant stability. Lamellar bone provides greater biomechanical stability, allowing the implant to withstand functional loads and remain securely anchored. This phase marks the completion of the osseointegration process, with the bone-implant interface becoming stable and resistant to external forces. The transition from woven to lamellar bone and the achievement of stable osseointegration typically takes about 1.5 years. This time frame ensures that the implant is fully integrated and capable of supporting functional loads without risk of failure. Osseointegration has significant clinical implications for dental and orthopedic implants. The process ensures that implants are securely anchored, providing reliable support for prosthetics and restorations. Understanding the steps and factors involved in osseointegration is essential for optimizing implant outcomes and ensuring patient satisfaction. Microscopic examination of the bone-implant interface provides evidence of successful osseointegration. The absence of soft tissue and the presence of direct bone contact are key indicators of integration quality. This evidence is essential for confirming the stability and success of the implant. Histologic sections of osseo-integrated implants can be compared to the roots of a tree, with the bone growing directly onto the implant surface. This comparison highlights the natural integration of the implant within the skeletal system, providing a stable and functional connection. Two theories regarding the chemical mechanism of endosteel implant integration with bone have been proposed. These theories explore how the implant surface interacts with bone tissue at the molecular level, influencing the success and stability of osseointegration. If the critical threshold of micromotion is exceeded during the healing phase, a fibrous encapsulation process occurs instead of osseointegration. This process involves the formation of soft tissue around the implant, compromising its stability and increasing the risk of failure. The debate between early and delayed loading of implants continues in implantology. Weiss advocates for early loading based on the presence of a fibro-osseous ligament, while Brånemark recommends delayed loading to ensure undisturbed healing and successful osseointegration. Understanding the pros and cons of each approach is essential for optimizing implant outcomes. Osseointegration represents a process whereby clinically asymptomatic rigid fixation of alloplastic material is achieved and maintained in bone during functional loading. This functional integration is essential for the long-term success of dental and orthopedic implants. Preventing implant failure requires careful management of functional loads, monitoring for adverse stimuli, and ensuring proper healing. Understanding the factors that influence osseointegration and the risks associated with overload is essential for maintaining implant stability and success. In summary, osseointegration is a process that enables direct and stable attachment of bone tissue to an implant without intervening soft tissue. The process involves several steps, from woven bone formation to lamellar bone replacement, and is influenced by factors such as material biocompatibility, surgical technique, and healing protocols. Understanding osseointegration is essential for optimizing implant outcomes and ensuring long-term success. The future of osseointegration research holds promise for improved materials, techniques, and protocols. Advances in biomaterials and surgical methods may further enhance the integration process, reducing healing times and increasing implant success rates. Continued research and innovation will ensure that osseointegration remains a cornerstone of modern implantology.